You wake up from anesthesia, and, well, the surgical team hands you this massive stack of discharge paperwork, right?
Yeah, usually while you're still half asleep and entirely confused.
Exactly. And the paperwork essentially contains this huge medical paradox. Like
Hmm.
on one page, the instructions are emphasizing this critical need to, rest and protect your incisions.
Right, the classic take it easy and stay in bed advice.
But then literally on the next page, you're warned about the dire consequences of immobility. They're telling you to get up and start walking immediately.
It is so contradictory for a patient to read.
It really is. So today we are decoding that exact tension. Welcome to the deep dive. We are taking a massive stack of medical guidelines, clinic recovery protocols, spanning everything from plastic surgery to orthopedics and cardiac rehab.
Plus some fascinating clinical studies and real patient forum discussions.
Yeah, all of it. Our mission today is to extract a really practical, science-backed roadmap for safely returning to physical activity. Specifically, we're looking at exercise, cycling, and swimming after you've had surgery.
Because we really need to debunk that persistent myth of just pure bed rest.
Exactly. We want to show how recovering your physical strength is not this passive state of lying down,
Right.
It's actually a highly active, very choreographed physical process.
It really is a choreography.
Hmm.
And to understand the mechanics of returning to a gym or a pool weeks later, we first have to look at the literal first hours after waking up.
Right, like right out of the operating room.
Yeah, because the trajectory of a months-long physical recovery is often dictated by, well, how a patient is managed in that initial 48-hour window.
Which is wild to think about. For decades, the default image of someone post-op was a patient just lying perfectly flat on their back in a hospital bed.
Staring at the ceiling.
Right. But the sources highlight a really decisive shift in modern protocols. There's this compelling data point from the Golden Jubilee National Hospital in Scotland.
Ah, yeah, the Fowler study.
Yes, the Fowler study. It focused on enhanced recovery after surgery, or ERAS. They tracked 240 elective orthopedic patients, so people getting hip and knee replacements.
And what they did was actually so simple.
So simple.
Yeah.
Instead of the traditional protocol where patients just recover flat in a hospital bed, the intervention group recovered, sitting slightly upright in a standard medical recliner chair.
Which is known as the Fowler's position.
Exactly. And the results are they're staggering.
They really are. I mean, the intervention is remarkably low tech, right? It's literally just a recliner. But the physiological outcomes are profound.
So the patients in the recliner group, they actually mobilized 22% faster than the ones in the traditional beds.
Yeah, and furthermore, their total length of stay measured until they met the clinical criteria to actually go home dropped by 18%.
Which, when you do the math, translates to saving an average of 11.8 hours of hospitalization, just by altering the angle of how they were recovering.
It's incredible. And the physiological mechanics behind that horizontal interval really explain those numbers.
Yeah, break that down for us. Why is lying flat so bad?
Well, when a patient remains completely flat, they actually face a much higher incidence of post-operative nausea, and it exacerbates the risk of post-operative hypotension.
Meaning low blood pressure.
Right. So when you attempt to transition from a prolonged horizontal state to a vertical one, you get this sudden fluid shift. That cardiovascular adjustment often causes a really severe drop in blood pressure.
Which is when people feel like they're going to pass out the second they stand up.
Exactly. Sitting upright continuously primes the cardiovascular system. Plus, it mechanically makes swallowing easier and aids gastric motility, which basically kickstarts your digestive system much earlier.
So you're physically ready to move. But there's also a huge psychological element here too, right? Like,
Yeah.
to me, being flat in a hospital bed just signals to your brain that you are sick.
Yes, you feel incapacitated.
But sitting in a recliner signals that you are recovering. It's a totally different mindset.
That cognitive component is huge. A recliner alters the environmental cue your brain is getting. And that Scottish study actually quantified the psychological shift.
Oh, right, the belief stat.
Yeah. 91% of the patients in the recliner group believed they would be able to mobilize on the day of their surgery.
Wow. 91%.
Compared to just 47% in the traditional bed group.
That is a massive difference in confidence.
And that psychological readiness is vital, because current surgical guidelines universally mandate walking within the first 24 to 48 hours.
Because they want to prevent blood clots, like deep vein thrombosis and post-operative pneumonia.
Exactly. You have to get the lungs and the blood moving.
Okay, so the first phase is basically just conquering gravity and walking to the bathroom. But once you transition home and get that basic mobility back, the challenge kind of inverts, doesn't it?
It really does. It goes from forcing a reluctant body to move to actively restraining a healing body from doing too much too soon.
Which is so hard for active people. When you look at the universal timelines from the sources, the progression is super rigid. Like weeks 1 and 2 are just restricted to light walking and breathing exercises.
Very, very light.
Then weeks 3 and 4, you could do low-impact movements and light household chores. Weeks 6 to 8, they finally introduce moderate activity like swimming or a stationary bike.
And it isn't until 12 weeks and beyond that you actually see clearance for full high-impact activities.
See, I read those week 3 restrictions and immediately thought about the athlete mindset.
Yeah.
Like if I'm in peak physical condition before a procedure and I wake up at week 3 with zero pain, my instinct is going to be, I'm fine, I'm going for a run.
Right, which is completely natural, but so dangerous. The cellular reality of wound healing dictates that pacing, not how you feel.
So the absence of pain is basically a misleading metric.
Entirely. Pain receptors are not an accurate gauge for cellular maturation. The surface incision on your skin can look perfectly sealed and be totally pain-free.
Right. It looks healed in the mirror.
But the underlying layers, the muscle, the fascia, the vascular networks, they are still structurally immature.
So in the first 2 weeks, the body's just managing acute inflammation and stopping bleeding.
Exactly, chemostasis. By weeks 3 and 4, the tissue enters this proliferative phase. The fibroblasts are laying down new collagen, but, and this is key, that collagen is highly disorganized.
So it's weak.
Incredibly weak compared to its pre-surgical baseline.
It kind of reminds me of wet concrete. Like on the surface, a newly poured sidewalk was completely solid and flat, you know?
That is a perfect analogy.
Right. But if you step on it too early, you might not shatter it into pieces, but you're going to leave a permanent structural dent in it.
Exactly. The internal vulnerability is just like wet concrete. If an athlete elevates their heart rate or their systemic blood pressure too high during that proliferative phase, they risk localized trauma.
What kind of trauma? Like internally?
Yeah, that elevated pressure can easily rupture those fragile, newly formed blood vessels. That causes hidden hematomas beneath the surface, or it can permanently widen and stretch out the maturing scar tissue.
Yikes. So to help active people navigate that fragile phase, Dr. Laura Devgan's guidelines offer this really great framework called the 50% rule.
I love this rule. It's so practical.
It really is. Basically, once you actually get medical clearance to start training again, the protocol is lift half your usual weight, do half your usual reps, and most importantly, apply double the mindfulness to how you're moving.
Yes, and a major component of that mindfulness involves strictly avoiding what's called the Valsalva maneuver.
Oh, right. This is so important for people who lift weights. Can you explain what that is?
Sure. The Valsalva maneuver is when you forcefully exhale against a closed airway. It's that standard bracing technique people use when they're lifting something really heavy, where you sort of hold your breath and bear down.
Like grunting through a heavy squat.
Exactly. Doing that dramatically spikes your intrathoracic and intra-abdominal pressure.
Which is exactly what you don't want when you have fresh internal stitches.
Right. Subjecting fresh sutures or delicate internal vascular connections to that sudden pressure spike, that is a direct mechanism for mechanical failure and internal bleeding.
And the guidelines also pair that 50% rule with a mandatory 24-hour check.
Because you won't always feel the damage immediately.
Exactly. The immediate feeling during the workout isn't the primary indicator of safety. The inflammatory response is delayed. So if you wake up the next morning with increased swelling or a new persistent ache,
you've exceeded your tissue's current capacity.
Yep. You have to wait 24 hours to actually understand the true impact of the exercise.
And, analyzing these general rules reveals another whole layer of complexity. The human body is this interconnected system, but it's also highly localized.
Right. Like what works for a knee surgery doesn't apply to heart surgery.
Exactly. The specific anatomical location and the mechanical nature of your surgery dictate entirely unique and, honestly, sometimes totally counterintuitive restrictions.
Let's actually trace that. Because the vascular and mechanical load of your workout interacts completely differently depending on the surgical site. Let's start with cosmetic and plastic surgery.
Okay.
Like a patient recovering from a facelift. They might logically assume, hey, my lower body is totally untouched, so doing some yoga is perfectly fine.
Right. Their legs and core are perfectly healthy.
But the guidelines strictly prohibit any inversion movements.
Yeah.
So no downward dog posture for at least 6 weeks.
Because of gravity and vascular pressure?
Exactly. The localized pressure from all that blood rushing to your head will directly exacerbate facial swelling and literally threaten the viability of the fresh incisions.
See, that principle of managing vascular pressure also dictates the protocols in cardiac rehab, just in a slightly different way.
Right, heart patients.
Yeah. Across all cardiac patients, cycling warm-ups have to last a minimum of 15 minutes, just to let the cardiovascular system adapt gradually. But there is this critical, very easily overlooked directive about riding a stationary bike.
The handlebar thing.
Yes. Patients are warned against gripping the handlebars too tightly.
Which I have to say totally surprised me. It seems so counterintuitive. If you're fatigued or your balance feels a bit wobbly, your natural instinct is to just brace yourself and hold on tight.
Of course it is.
So what is the actual danger of a tight grip?
It comes down to isometric tension. When you grip tightly, you create a sustained isometric muscle contraction in your forearms and hands.
Meaning the muscle is flexing but not actually moving or changing length.
Exactly. And that specific type of sustained tension causes a really disproportionate artificial spike in your systemic blood pressure.
Wow.
Yeah. So for a cardiac patient actively recovering from heart surgery, introducing an unexpected posture-induced blood pressure spike is a huge risk factor.
Just from gripping a handle too hard. That is wild.
It is, which is why, to keep cardiovascular exertion safe, cardiac guidelines rely on the Borg rating of perceived exertion scale.
The RPE scale.
Right. Patients are told to stay between an 11, which is light, and a 13, which is somewhat hard. And the practical everyday application of this is the talk test.
Ah, right. If you can't speak in a full, uninterrupted sentence, you're working too hard.
Exactly. The cardiovascular demand is just too high at that point.
Okay, so shifting from vascular pressure to mechanical friction and anatomical load, the restrictions get even more specialized.
You really do.
A prime example from the sources is labiaplasty, or labial reduction surgery. Because of where that surgical site is located, it is highly prone to direct friction and bearing body weight during certain activities.
Especially sitting activities.
Exactly, which is why returning to a bicycle is strictly regulated. Light, non-vigorous activity on a stationary bike might be okay around 4 to 6 weeks, but road cycling, or horseback riding, has to wait a full 6 to 8 weeks.
Because the repetitive friction and the direct structural pressure from the saddle would just rapidly break down that healing tissue.
Right. And we see similar localized protection strategies in breast surgery protocols.
Yeah.
Like after an augmentation, a reduction, or a lift, the pectoral muscles have to be shielded from heavy pushing or pulling.
So no standard push-ups.
Right. When patients are finally cleared to start rebuilding chest strength around weeks 3 or 4, the protocols specifically mandate wall push-ups rather than traditional floor push-ups.
Because standing against a wall modifies the angle of gravity. It lets you engage the muscles, but minimizes that sheer, tearing strain on the chest wall.
Exactly. Now, if you think that's restrictive, the anatomical load considerations in open-heart surgery are even more extreme.
Oh, absolutely. The sternum takes a long time to heal.
Right. A patient recovering from a heart attack might get back to road cycling in about 4 weeks. But an open-heart patient faces an 8 to 12-week delay.
And it has nothing to do with their actual heart muscle capacity.
No, it's pure skeletal mechanics. The sternum, the breastbone, gets divided during the procedure. It literally needs 8 to 12 weeks to fuse and calcify enough to support the weight of your upper body leaning forward over a set of handlebars.
If you lean over too soon, you could literally pull your ribcage apart.
Which is terrifying.
Yeah.
And this interaction between surgical sites and complex movements is also super evident in orthopedic and optical procedures.
Definitely. I mean, think about a hip replacement.
Right. A patient with a new hip might have a fully recovered cardiovascular system. They're ready to jump in the pool and swing. But specific orthopedic guidelines strictly forbid swimming the breaststroke.
Because of the frog kick motion.
Exactly. That distinct frog kick generates external rotation and torsion right on the hip joint. It creates a severe risk of dislocating the new hip.
And similarly, optical guidelines for eye surgery are entirely focused on environmental hazards and localized impact.
Like post-cataract surgery, patients are barred from swimming for 4 to 6 weeks.
Yeah, and if you have a cornea transplant, you face a 1 to 3 month ban on pool activity. No diving whatsoever, and wearing goggles is absolutely mandatory.
Because the ocular tissue just cannot withstand that sudden hydrodynamic impact, right?
That, and the risk of bacterial introduction is just way too high.
Which really highlights why relying on just generalized internet fitness advice is so dangerous.
You have to get clearance directly from your surgical team. They're the only ones who know the specific internal anatomy of what was done.
But, and here is where it gets really interesting, The sources also document that even when you follow the timelines, even when you follow all these procedural quirks perfectly, the real-world application can still expose you to unexpected danger zones.
Oh, for sure. Because clinical theory assumes this idealized, controlled environment. But patients are operating in gyms and homes filled with unpredictable mechanical variables.
Right. The patient narratives from the Mayo Clinic Connect forums provide such vital context here. They show how tiny environmental variables can just completely derail a textbook recovery.
There was that one really detailed account from the 70-year-old man.
Yes. The man recovering from a robotic prostatectomy, a RALP. He did everything right. He waited the mandated 6 weeks, he felt totally asymptomatic, and he went back to his gym.
But then he chose the wrong machine.
He chose a seated bench press machine. But the seat on this specific piece of equipment was really small and triangle-shaped.
Which is a disaster for prostate recovery.
Exactly. That specific geometric shape directed all the mechanical load of the exercise straight into his perineum. The pressure caused immediate severe pain, and when he tried to lift heavier weights, he actually experienced minor incontinence that he hadn't had before, that specific localized stress.
It is such a striking example. The specific shape of a gym seat is a variable that no clinical protocol can possibly account for, yet it interacts so negatively with the healing internal structure.
Another forum user shared a story that perfectly illustrates our earlier discussion about internal pressure and the Valsalva maneuver. This patient actually required full reparative urethral surgery at 6 weeks post-op.
And it wasn't from a gym workout, right?
No. The injury resulted entirely from straining excessively during a difficult bowel movement.
Wow. But that mechanism of injury aligns exactly with the dangers of holding your breath and bearing down.
It does. The internal pressure generated within the abdominal cavity during a heavy squat is virtually identical to the pressure generated during severe bathroom straining.
The healing tissue, the urethra in this case, it doesn't know the difference between the sources of the pressure. It simply succumbs to the mechanical force.
So navigating all these hidden mechanical traps requires constant vigilance. The protocols dictate that certain symptoms just have to be treated as absolute stop signs.
Like asymmetrical swelling.
Right, where one limb or one side of your chest exhibits more swelling than the other.
Or any new exudate, oozing from an incision site.
Right, those are not indicators to push through. They mandate an immediate halt to whatever activity you're doing and a direct consultation with your surgical team.
We also need to talk about the environmental hazards of aquatic recovery because people always want to get back in the water.
Oh, yes. The swimming guidelines are super unambiguous. Submerging your incisions in baths or pools is strictly prohibited until the wound is completely and permanently closed.
Which is not as fast as people think. Superficial closure might happen in 10 to 14 days, but clearance for public pools is routinely extended to 4 to 6 weeks.
Because of the bacteria.
Exactly. The bacterial load in public aquatic environments poses a completely unacceptable risk of a severe systemic infection if there is even a microscopic opening in your tissue barrier.
That makes total sense. And, long-term management of the body's systems extends way beyond just the initial wound closure, especially when it comes to lymphatic health and scar maturation.
Right. For procedures involving lymph node removal, like many oncological surgeries, the localized lymphatic drainage system is permanently altered.
So the guidelines warn against prolonged repetitive physical activity that overwhelms that compromised system.
Yes. Patients have to incorporate strict breaks every 1 to 2 hours just to change positions and facilitate lymphatic return. And they have to actively manage their BMI to reduce the overall burden on that network.
And managing the scar tissue itself is a continuous process, too. Once the incision is fully healed, daily scar massage becomes a really critical physical therapy tool.
Typically about 10 minutes a day, utilizing a simple, unscented moisturizer.
Right, because that mechanical manipulation prevents adhesions, where the internal layers of muscle, fascia, and skin heal inappropriately bound together.
Regular massage maintains tissue elasticity, promotes localized lymphatic flow, and basically prevents chronic swelling.
We have really mapped out a complex, highly localized landscape today. The sources make it so clear that optimizing recovery means abandoning that horizontal hospital bed for the Fowler's position right off the bat.
It means treating your pain-free body like wet concrete.
Exactly. Using Dr. Devgan's 50% rule to build strength without ruining your structural integrity. We've seen how vascular mechanics dictate everything from avoiding downward dog after a facelift to easing your grip on a stationary bike during cardiac rehab.
And how localized anatomical vulnerability means no breaststroke after a hip replacement or staying off a bike saddle after a labiaplasty.
It is truly a process of constant vigilance against unexpected mechanical loads.
Mm.
I want to turn it over to you for a final thought as we close out this deep dive today.
When synthesizing all of these diverse medical protocols, a really profound philosophical shift emerges for the listener.
How so?
Well, habitually, we frame post-operative recovery as this frustrating interruption. We view the weeks spent walking slowly or lifting half our usual weight as lost time in our broader fitness trajectory.
Right, like we're just waiting to get back to normal.
Exactly. But analyzing the sheer complexity of tissue healing suggests a totally different perspective.
Hmm.
What if this period is not a setback, but rather a mandatory masterclass in body awareness?
Oh, I like that.
A surgical recovery systematically strips away your fitness ego. It forces this hyper-focused attention on the mechanics of your breathing, the nuances of your posture, the precise distribution of pressure on a joint, and the subtle signals of vascular strain.
It demands that you listen to the body's whispers before they escalate into screams.
Precisely. So consider how carrying this level of exquisite mechanical mindfulness into your regular routine could permanently elevate the way you train. Long after the incisions have fully matured and the scars have faded, maintaining that deep analytical connection to your physical mechanics ensures that returning to exercise isn't just about reclaiming your previous baseline.
It's about more than that.
It is. It's about rebuilding a fundamentally smarter, more resilient relationship with the only body you have.